Welcome to KDIGO Conversations in Nephrology. This episode in our complement-mediated kidney disease series, titled Advancing Research and Novel Therapies for C3G, is provided by KDIGO and supported by Apellis and Sobi. Here's your host, Dr. Carla Nester.
Hello, and welcome to KDIGO Conversations in Nephrology. I'm Dr. Carla Nester, Professor of Internal Medicine and Pediatrics, Stead Family Children's Hospital, University of Iowa, and joining me to discuss advancing research and novel therapies for C3G is Dr. Nicole van de Kar. Dr. van de Kar is a pediatric nephrologist at Radboud University Medical Center, Nijmegen, the Netherlands, and her clinical and research interests include thrombotic microangiopathy and the complement-mediated kidney diseases. Dr. van de Kar, welcome to this podcast.
Thank you, Dr. Nester. It's a pleasure to be in this podcast.
Let's begin our discussion today with the first question. Let's start with your view of what the next decade, as compared to the last decade, of course, in therapeutics will look like in the treatment of C3G.
Well, thank you for this question. I think this will be really an exciting decade which we are going into, because now we can make the diagnosis by kidney biopsy in C3G, and we have already supportive therapy which we know as RAS blockades and low salt diet, and we have already for years the immune suppressive treatments as prednisone and MMF. But that is all non-targeted treatment. And you can read all these protocols in the KDIGO guidelines, for example. But what is now intriguing is that we have now the first time targeted treatment available for C3G. And that's because of those two new drugs which have now entered. They ended almost the clinical trials. And then for the first time, we have a targeted therapy, which will target the overactive complement alternative pathway. As we know and we heard before, this is the driver of the disease. So this next decade, having these complement inhibitors available for the treatment will be exciting. And I think it will lead to less chronic renal damage, less end-stage kidney failure, and hope for those C3G patients who need a kidney transplant, and hope for a better future for all C3 patients. So I think this next decade will be really promising.
I think you're exactly right. This idea of targeted therapeutics for the first time in our lives in this set of diseases is amazing. A small question, and I don't want you to have to think about it too hard, but do you think there are going to be issues about how to use them? For instance, are you going to consider primary therapy? Are you going to consider whether you have to do X, Y, or Z first?
I think for us as clinicians, it will be very important to draft good protocol when to use these new drugs, for whom, on which conditions, and how to follow them up and how to monitoring them. Because in the trials, the patients were not mostly primary having the disease for only a couple of weeks or months. Some were already having them for years and entered the trial. So I think there will be definitely people who can use it in the first weeks of the disease, but then really well guided by protocols, I guess. What will be the criteria to use for?
Yeah, I think that's an excellent approach, this idea of developing protocols. So then the next question, which is a little bit unfair, because obviously neither one of us are pharmaceutical people, but when designing these trials, for these agents, what's your impression of how the sponsors decided upon the endpoints that they decided upon?
Well, I was not involved in designing the clinical trials, but I participated, as you as well, in an international working group organized by the Kidney Health Initiative in 2021 to address the challenges needed to say what do we need from these trials and what outcome do we need and what are the best endpoints. And we had a lot of discussions in working groups and it went back and forth. And at the end, we came up with 3 endpoints, which might for C3G might be very valuable. And those are also endpoints you see in the trials. And for me, I think the most important one is proteinuria. It's a risk marker for disease progression across various glomerular disorders, so not only C3G. And we know that large treatment effects on proteinuria are believed to predict treatment effects on disease progression. If you then look at C3G, then we have not that much data in time how patients are doing on the treatments. But we see that from cohorts in the United Kingdom and also from Iowa, that if we can reduce the proteinuria, and if you can reduce it 50% or even more, I think, then it will, at the end, will benefit also your eGFR, so your kidney function, and it will, at the end, will be of health for your kidney function. The problem is for proteinuria that it's not really an endpoint which is much used in clinical studies. So is it then good? Is it a bad endpoint? I think it's the best we have at the moment. And I think you would expect an effect at 6 months at least. So for that, I think it will be a good endpoint and the best we have at the moment. Of course, if you ask in our group as clinicians, we also know that proteinuria can be difficult, because we are aware that, of course, if you have sclerotic regions in your kidney, you also have proteinuria. And together with declining kidney function, we know that this is different proteinuria. This is proteinuria because of fibrosis. And so this will always be an issue, having proteinuria as an endpoint. But I think looking at creatinine function, at kidney function, looking probably also at histology, it might help. So this, I think, proteinuria is a good one. And next we have the eGFR. We discussed it as well in our working group. And of course, you would expect if the inflammation in your kidney caused by the overactive complement activation will decline by using these drugs, you could imagine that your kidney function will in time improve. And the slope of your eGFR will then get less steep, so your kidney function will improve. We don't have data, retrospectively data, to see what will be the best follow-up time. But I think also here 6 months is fair to mention that you probably would not need a very deterioration of your eGFR, because if that's the case, if your eGFR is deteriorating or going badly with the new drugs, you might wonder if something is wrong and you have to rethink again. So that's very important, I think. And then you have the histology. It's a rare disease and you only do kidney biopsy if you think really it's needed. So we don't know what we have to expect in kidney biopsies. You might think the new complement blockers inhibit C3 activation. So there might be a reduction in C3 deposits in the kidney. And you might think in time you will be seeing that in your histopathology. But that means that you have to rebiopsy patients again. And I think this is something which we really need to think of if we want to do it and what we want to see. So I think what we see in the trials is that they looked at histopathology and that was mostly the secondary endpoint. And they had, for example, they had an histological activity index. But in this score, there's also necrosis or fibrosis mentioning. So we have to define what do we want to see in histopathology, which could improve the kidney health. And probably the deposits is one of the most important things, but less fibrosis, if there's already something there, would be a benefit as well.
Yeah, I think all of your points are very important. I think we weren't as fortunate as, for instance, IgA to have that proteinuria as already a selected surrogate endpoint for our regulatory agencies. And when you think about the GFR, you can't wait, the years it takes for the GFR to decline enough for you to get to dialysis, right? So you have to think about, what measure of the GFR are you going to pay attention to? And you kind of already brought up the important part, because one of my questions was going to be, if you rely on histology, which certainly the animal models would have supported, that if you stop the alternative or if you block the alternative pathway, that maybe the histology goes away. That means you have to go back to rebiopsy. Two small questions about, and they're actually not small questions, but so you've already told me you would rebiopsy. Are your patients in general going to agree that that's okay?
I think I would rebiopsy if I don't see enough improvement in proteinuria, or if I hardly see any improvement in proteinuria. And I would also rebiopsy if I see the kidney function is declining. This is really for me a must to biopsy, because that has consequences. If everything is going well, then you might wonder, are we going to biopsy? And this is a difficult point, because we should, in the ideal world, if biopsies would not do any harm, if it would be easy doing it, I think it would be good to do, because we could see what the effect is in time of these new drugs on the histopathology. But that might be difficult to get patients and also clinicians into rebiopsy when things are going well.
Yeah, I think you're exactly right. But you also make the point that we need the real world experience to help us solve some of these issues. So perhaps you can share a brief overview of the clinical trial results in general. I know some of that, like you've said, has been published and some of them are waiting for publication. But if you wanted to share just a little capsule of that for our listeners.
Well, it already started a couple of years ago with, I think, the first international trial on complement blockade in C3G was the avacopan trial. It was a phase 2 trial. Avacopan, we know now because it's now implemented in ANCA vasculitis treatment, but it's an oral blocker of the C5a receptor, blocking the effect of C5a. And it was thought it might have a role in C3G. And it was designed really good, double blind, placebo controlled. And the endpoint was, there we come to the histology again, the endpoint was an improvement in histological activity at 6 months of using the product. And this endpoint was not achieved. There was no significant difference between avacopan and placebo. Although there was reduction in proteinuria by those who were treated by avacopan in comparison with those with placebo, but this trial did not made it further on. And then we had, I think mostly at the same time actually, there was a trial, also a multicenter international trial on danicopan. And that's a small molecule inhibitor of the complement factor D, also of the alternative pathway. Not also, because avacopan is targeting the terminal pathway, but danicopan is more upstream. And that danicopan is cleaving factor B. It prevents cleavage of factor B, and therefore it reduces the C3 convertase formation, which is seen as the culprit of C3G. And this trial was a phase 2 trial, also double-blind, placebo-controlled, but the efficacy was found to be limited. It was probably failing achievement in complement inhibition. And although there were some patients showing a decline in proteinuria, I think it was not showing good results. So it was stopped. And then I think where we all have been waiting for, and we see those results of 2 phase 3 trials of complement inhibitors targeting at the level of C3, so at the C3 convertase, those are the iptacopan and the pegcetacoplan. And both trials have reached now their inclusion rate of patients, and they are finalized or getting finalized and are almost ready or far ready to publish their results. And I think iptacopan, for example, an oral factor B inhibitor, selectively blocks the formation of the C3 convertase of the alternative pathway. This phase 3 trial has been performed in adults. And this is now already the drug which is registered because of the results by the FDA and the EMA in the treatment of C3G in adults. And we have to await for the adolescents trial, which is still going on, but already very far ahead for their results. So then we have pegcetacoplan. It's a C3 blocker, activation level of C3. And this drug actually acts at C3 and therefore acts on all 3 complement pathways, including the alternative pathway. And that is a drug you need to give subcutaneously, twice weekly. And for this phase 3 trial is in adolescents and in adults. So they combine it, and it's in C3G, but they have also primary immune complex MPGN. And they have also included patients who are known with C3G but have already a renal transplant. And actually, those drugs have already shown good results, as you probably aware of. And I think the design was for both trials was they all had a 6 months, so 26 weeks, or placebo or drug. And then after 26 weeks, all got the drug. And I think the results have been published for the first 6 months of both drugs.
Yeah, so thank you for that overview. If you are just tuning in, you're listening to the KDIGO podcast on advancing research and novel therapies in C3G. I'm Dr. Carla Nester, and I'm speaking with Professor Nicole van de Kar, Pediatric Nephrology, Nijmegen. So I'm going to ask you, and I might be able to guess since you're a pediatric nephrologist, can you share with us some of the distinguishing features between the studies that end up being important given what kind of patients you're approaching?
Well, I think what they did in both studies, I think the trial design was at quite some similarities. Adolescents need to be above 12 years. So we don't have data on below 12 years. And you and I know that we see children which are younger than 12 years as well. They all wanted to have an active disease. They all wanted the eGFR above 30 ml per minute. They all want to have more than 1 gram per gram proteinuria in 24 hours, or in first morning urine also more than 1 gram per gram. So that makes it, you already have an exclusion of patients who have less than this 1 gram or don't have the age of 12, you need mandatory vaccination. I think that's very, very important. We are aware of that for the other diseases, atypical HUS and PNH, that you need vaccinations against the meningococcal, pneumococcal bacteria, and Haemophilus influenza. So that was all in all of them. So that was one thing. And I think the exclusion criteria were almost all the same as well. So you were excluded if you had more than 50% sclerosis in your kidney biopsy. Secondary forms of C3G, so mostly post-infectious and the monoclonal gammopathy were excluded. And you need to not have to have an exposure to other complement inhibitors. But you were allowed to have ACE or ARP inhibition or SLG2, at least for adults. We are not allowed to use it in Europe for children. And you were allowed to have prednisone or corticosteroids and MMF. But you need to be on a stable regimen for those drugs. So those were actually having somehow the same results, the same inclusion or exclusion criteria. But of course, the way of action is different. One attacks factor B, the other attacks C3, iptacopan orally, pegcetacoplan subcutaneously. And that means that you already have some differences between those drugs. If we look at the results, the results for both studies look good. Iptacopan had a 35% reduction in proteinuria, change in proteinuria compared to the baseline and versus the placebo. It had a stabilization on the eGFR in 12 months, so that's very good. The pegcetacoplan, where C3G and immune complex MPGN is included, showed a reduction from 67% reduction in proteinuria compared to the baseline as compared to placebo. And they could show a small improvement on eGFR at 6 months. And they had already looked at more biopsies than iptacopan at this time, and they could show in less staining or in a lot of zero staining on C3G in kidney biopsies. So both drugs do really work as it looks. On the complement overactivation we found in C3 Glomerulopathy. So that's very good.
Thank you. That's a very good representation of the trials, and I agree. They both work very well. I'm curious, and I recognize we don't have data for this, but you mentioned they both required a 1 gram of urine protein, somewhat like the IgA world these days. Do you think once we get to real world, we'll be interested in using it before a gram, or do you think most of us will stick to the gram?
Depends. I think if you have a new patient and it's above the 1 gram, I think always you start with ACE or ARP. And probably you will get already quite some patients having a reduced proteinuria, maybe even below 0.5 gram a day. And then becomes the questions, and are we going to give those then already immediately a complement inhibition? Are we doing it instead of prednisone and MMF, which is at the moment the standard therapy, or we add first with the ACE and the ARP, we add prednisone and MMF, and together with complement inhibition. So I think this is really stuff to have good thinking about what we are going to do. It's also, those drugs cost lots of money. And if we want to have it available for a good treatment in our C3T patients, probably we should not use those complement inhibition drugs in those who have less than 1.5 gram a day. And maybe even not with 1 gram. We should start with ACE and ARP and see what comes out, and then progress with maybe prednisone and MMF. But I know there are also colleagues who would like and love to start with the complement inhibition right away. But depends if attacking of the overactivated complement system would be enough in the first weeks of your disease, if there is such an inflammation already there, which is broader than only the overactivation of the complement. Should we then still need immune suppressive drugs, for example, for a short while? What would be the best protocol?
I think you're exactly right. I think at the end of the day, we still have some thinking to do on this. We still have to figure out, is attacking inflammation critical? Is targeting the complement system critical? Is targeting the protein critical? Or even, for that matter, the CKD aspects, as you've kind of indicated. There's a number of supportive cares. So the final point on that might be that, will the standard of care change? We know what has been set by KDIGO currently. We have to decide what happens next, don't we? And more to come, I'm sure. But then maybe one of the final questions I'll have for you is that if you could pick one or two, or maybe just a very few, what are the biggest challenges you think that we're going to face? And we started this discussion about what's the next decade look like? Well, what's the next decade look like when it comes to challenges in this setting?
I think I want to play out for all the clinicians treating patients with C3G. Unite yourself to gain more data on C3 patients and their treatment, whatever treatment it is. I mean, if it's ACE, if it's ARB, if it's prednisone, corticosteroids, and we really need good, well thought of treatment protocols. We have to collaborate with each other to make those protocols. And I think there are initiatives already going on, which I really encourage, and I really think they're very important. And we really have to work together on an international way to make this collaborative databases, because then we can see what the landscape looks like and what the drugs will do. I clearly think that the standard treatment care will change for C3G, and complement inhibition will find its place somewhere in those protocols as well. But then it will be very, that like we discussed, when to start, which complement inhibitor use. Is there a moment to stop? Can we stop? Do we have to treat those with autoantibodies against the C3 convertase? Do they need the same treatment as those with genetic variation, for example? And I'm very curious, can we get complete remission in all C3G treated patients with complement inhibition, for example? And this is a more important challenge for us as clinicians. We have to monitor the efficacy, I think, as well, and the side effects. And that's what I told earlier. If you don't see a benefit, let's say in 3-6 months of your therapy, the thing we consider, maybe you need to rebiopsy again. You need to think if this drug is effective enough. And also, if you think of complement inhibition on a long time, is it safe in your growing child, in adolescent? I still don't know. I mean, we have just started with atypical AGS, of course, and PNH, and we are still figuring out. And I think we are very lucky and for seeing these results of these new therapies, but it doesn't change anything on the presence of the autoantibodies against the C3 convertase. So at the overactivation of the complement system, we can act with those blockers, but we can not do anything on those autoantibodies. So that might be a challenge for future trials, maybe in combination with complement inhibition, to see if we can get rid of this autoantibodies as well. Some will disappear by themselves in time, but some will stay there for a long time and will continue to overactivate the complement system and possibly ongoing C3 glomerulopathy. So I think, well, it's really an interesting decade which we are going into as clinicians and as patients, but promising, very promising.
That's exciting. Even hearing you talk, it gets very exciting. So what I hear you say is, for one thing that's going to be important is this idea of global teamwork, this idea of all of us collaborating to get the answers that we need. But also, I think you make a very good point of, just surveillance of what happens and what do we need to do next. So those are all fantastic points. And I thank you very much for identifying all of those challenges. We're about to wrap up. So before we wrap up completely, Dr. Van de Kar, I thought I would ask you very quickly, do you have any final messages that you want to share with us? Perhaps you've said most of them, but if you have a few that you'd like to add, please do.
I think if you, those who are listening, have patients with C3G in your practice and you're looking out for those new promising new treatment options, but please try to contact your colleagues in expertise center or reach out to other colleagues who treat C3G patients and try to do it in a protocoled way. Whatever protocol, but make one and stick to that or look for it. And then I think make sure that your patient is somewhere in a national or international database, because we have to learn from now on how to use these treatments, and this learning has just begun.
I think that's an excellent message. So thank you, Dr. Van de Kar, for joining me for this session. It was really great having you here, and you clearly have a number of wonderful insights into what this new decade will look like for us. Thank you for joining us.
Thank you. It was a pleasure. Thank you for having me.
I'm Dr. Carla Nester. To access this and other episodes in our series, visit kdigo.org/podcast. Thank you for listening.